Welcome to this lecture on Basic Life Support, BLS, Resuscitation. As an EMT, mastering BLS skills is essential for saving lives in emergencies like cardiac arrest, airway obstruction, and respiratory failure. Time is everything. Acting quickly and effectively can mean the difference between life and death. BLS has been the foundation of emergency care since 1960. Over the years, techniques have been reviewed and refined to improve survival rates. The latest update in 2020 by the International Liaison Committee on Resuscitation (ILCR) ensures we're following the best possible guidelines for patient care. BLS is non-invasive emergency life-saving care used for conditions like airway obstruction, respiratory arrest, and cardiac arrest. These are critical situations where every second counts, and quick intervention can save a life. BLS focuses on the ABCs of emergency care. A. Airway. Is the airway open or obstructed? B. Breathing. Is the patient breathing on their own? C. Circulation. Does the patient have a pulse, or are they in cardiac arrest? If any of these are compromised, immediate action is required. Seconds matter. Ideally, BLS should begin immediately after recognizing a patient is in distress. Brain damage can start within 4 to 6 minutes without oxygen. The faster you intervene, the better the chances of survival. This image highlights how quickly brain damage can occur when oxygen supply is cut off. After 4 to 6 minutes, permanent damage is possible. At 10 minutes, survival without severe impairment is unlikely. This is why immediate action is so important. Cardiopulmonary resuscitation, CPR, is the key to restoring circulation and artificial ventilation in a patient who isn't breathing and has no pulse. High-quality CPR can keep blood and oxygen moving until advanced care arrives. CPR follows 3 basic steps. Restore circulation with chest compressions. Open the airway using the head tilt chin lift or jaw thrust. Restore breathing with rescue breaths or a bag mask device. Every step must be done correctly to maximize the chance of survival. Quickly identifying cardiac arrest is crucial. If a patient is unresponsive and not breathing normally, begin BLS immediately. Hesitation or delay can cost the patient their life. BLS differs from advanced life support, ALS. While BLS focuses on basic interventions like chest compressions and rescue breaths, ALS includes advanced skills like cardiac monitoring, for medications, and advanced airway management. This image shows the 6 links in the chain of survival. Each link is critical to increasing the patient's chance of survival. Missing even one step can reduce their likelihood of recovery. The AHA chain of survival includes recognizing cardiac arrest and activating EMS, performing high-quality CPR immediately, rapid defibrillation with an AED, effective EMS response, post-cardiac arrest care in a hospital, recovery and rehabilitation. Each step plays a role in improving survival rates. Always start by assessing the scene. Is it safe? Are there any immediate dangers? Once safe, complete a primary assessment. Check airway, breathing, circulation, and responsiveness. This should take less than 10 seconds. BLS principles are the same for all ages, but in adults, cardiac arrest usually happens before respiratory arrest, while in infants and children, respiratory failure leads to cardiac arrest. This difference is crucial when determining treatment priorities. When assessing an unresponsive patient, tap their shoulder and speak loudly. If there's no response, check for breathing and a pulse immediately. Time is critical. Every second of delay decreases survival chances. An AED is a vital link in survival. If a cardiac arrest is witnessed, start CPR and apply the AED as soon as possible. The sooner defibrillation occurs, the higher the chance of survival. For children, apply an AED after 5 cycles of CPR unless it's a witnessed arrest. Always use pediatric pads if available. If not, adult pads with anterior-posterior placement can be used as an alternative. Special situations require modifications. Pacemakers and defibrillators. Avoid placing pads directly over these devices. Wet patients. Dry them before applying the AED. Medication patches. Remove and wipe the area before applying pads. For effective CPR, the patient must be lying flat on a firm surface with enough space for two rescuers to work. If needed, use a log roll to position them on a backboard. Check for breathing and a pulse at the same time. Look for chest rise, and feel for a carotid pulse in adults. This should take no longer than 10 seconds. If the patient has no pulse, begin chest compressions. Proper technique ensures compressions pump blood effectively. Do not lean on the chest between compressions. Let it fully recoil. Proper hand placement is key. Place both hands on the lower half of the sternum. Poor technique can cause injuries, so always check positioning. This image highlights the location of the heart in the chest. Compressions must be deep and consistent to effectively circulate blood. Compression and relaxation should be rhythmic and equal. Use a 1-to-1 ratio. Compress, then release fully. If the chest doesn't recoil, blood flow is reduced, making CPR less effective. If no spinal injury is suspected, use the head tilt, chin lift maneuver to open the airway. Place one hand on the forehead, apply gentle pressure to tilt the head back, and lift the chin with 2 fingers. This prevents the tongue from blocking the airway. If the patient is breathing adequately and has no suspected spinal injury, place them in the recovery position. This keeps the airway open and allows fluids like vomit to drain, preventing aspiration. The recovery position helps maintain a clear airway in a patient who is breathing but has a decreased level of consciousness. This is especially useful for overdose or post-seizure patients. A lack of oxygen combined with too much carbon dioxide is lethal. If a patient is not breathing, ventilations must be provided immediately. Use a barrier device or bag mask to deliver breath safely. For effective ventilations, use a bag mask device with an airtight seal. Deliver slow, controlled breaths. Too much pressure can force air into the stomach, causing vomiting and aspiration. For patients with a stoma, place the bag mask directly over the stoma. Be aware that gastric distension may occur, so have suction ready in case the patient vomits. Ventilating a patient with a stoma can be tricky. If air is escaping from the nose or mouth, you may need to gently seal those areas to ensure all air goes into the lungs. When working alone, perform 30 compressions followed by 2 breaths at a rate of 100 to 120 compressions per minute. High-quality compressions with full recoil are the key to success. 2 rescuer CPR is always preferable to 1 rescuer CPR because it allows for higher quality compressions. Rescuers should switch every 2 minutes to prevent fatigue. Smooth transitions keep compressions going without interruption. Newer CPR technology includes active compression-decompression devices, which pull the chest upward after compressions to improve circulation. The impedance threshold device, ITD, helps improve blood flow by reducing air entry into the lungs between compressions. This image shows an active compression-decompression device and an impedance threshold device, ITD. These tools can improve circulation but should only be used by trained providers. Mechanical CPR devices, like piston-driven machines and load-distributing bands, can deliver consistent, high-quality compressions. While effective, manual CPR is still the standard of care when these devices are unavailable. Here is an image of a mechanical CPR device, also known as a load-distributing band. For pediatric patients, respiratory arrest usually leads to cardiac arrest, so airway and breathing take priority. The faster oxygen is restored, the better the child's survival chances. Common causes of pediatric respiratory failure include injury, infection, choking, drowning, electrocution, poisoning, and SIDS. Always consider these possibilities when assessing an unresponsive child. To assess responsiveness in an infant or child, gently tap their shoulder and speak loudly. If there's no response, check for breathing and a pulse simultaneously, and begin CPR if needed. Foreign body obstructions are common in children. If a child is unresponsive but still breathing, place them in the recovery position. If CPR is needed, modify airway techniques by placing a small wedge under the upper chest and shoulders. For rescue breathing. If the child has a pulse but isn't breathing, give one breath every 2 to 3 seconds. If the child has no pulse, perform 30 compressions followed by 2 breaths. CPR should continue without interruption until ALS arrives or transport is necessary. If no ALS is available, follow local transport protocols while continuing CPR. The chest compression fraction is the percentage of time during a resuscitation when compressions are actively being performed. This should be at least 80%. The higher, the better. CPR should not be started if the scene is unsafe. The patient shows clear signs of death, such as rigor mortis, lividity, or decomposition. The injuries are obviously non-survivable. This image shows dependent lividity, where blood settles in the body after death. If lividity is present, CPR is not appropriate. If a do not resuscitate, DNR order is present, CPR should not be started. However, if there is any doubt, begin CPR and contact medical direction for guidance. CPR should continue until S. The patient starts breathing and has a pulse. T. The patient is transferred to a provider with higher level training. O. You are out of strength and physically unable to continue. P. A physician directs you to stop. A blocked airway can be caused by relaxed throat muscles, vomit, blood, dentures, or foreign objects. If the patient can't breathe, immediate action is needed. The abdominal thrust maneuver, Heimlich, is the best way to remove an obstruction in a conscious adult or child over 1 year old. Stand behind the patient and thrust inward and upward until the object is expelled. The abdominal thrust maneuver, Heimlich, is the best way to remove an obstruction in a conscious adult or child over 1 year old. Stand behind the patient and thrust inward and upward until the object is expelled. The abdominal thrust maneuver in a responsive adult. Stand behind the patient and wrap your arms around the patient's abdomen. Place the thumb side of one fist against the patient's abdomen while holding your fist with your other hand. Press your fists into the patient's abdomen, using inward and upward thrusts. For pregnant or obese patients, abdominal thrusts may not be effective. Instead, use chest thrusts by wrapping your arms around the patient's chest and applying inward pressure against the sternum. This image demonstrates the proper chest thrust technique for removing an obstruction in a conscious patient who is pregnant or obese. The motion should be firm but controlled to avoid injury. If a patient becomes unresponsive, lower them to the ground and begin CPR immediately. After each set of 30 compressions, open the airway, check for the obstruction, and remove it if visible. Never perform a blind sweep. Only remove objects you can see. Choking is a common emergency in infants and children. If a child is conscious and standing or sitting, perform the Heimlich maneuver. If the child is unresponsive, manage them the same way as an unresponsive adult. This image demonstrates the abdominal thrust maneuver on a child. Kneel behind them, wrap your arms around their body, and place your fist just above the navel but below the sternum. Perform quick, inward and upward thrusts. For infants under 1 year old, Do not perform abdominal thrusts. Instead, use a combination of back slaps and chest thrusts to remove the obstruction. This image shows the correct infant airway obstruction technique. Hold the infant face down, supporting the head, and give 5 back slaps between the shoulder blades. Then, turn the infant over and provide 5 chest thrusts using 2 fingers on the lower sternum. If an infant becomes unresponsive, begin CPR immediately. Do not check for a pulse before starting compressions. After every 30 compressions, open the airway, look inside the mouth, and remove any visible obstruction before continuing. In opioid overdoses, standard resuscitation takes priority over naloxone. If the patient is in respiratory or cardiac arrest, start CPR and ventilation immediately before considering naloxone administration. In pregnant patients, high-quality CPR is the first priority. To improve circulation, manually displace the uterus to the left to relieve pressure on the aorta and vena cava. This increases blood flow and oxygen delivery to both the mother and baby. Family members experiencing a loved one's resuscitation may face a psychological crisis. They will remember this event for the rest of their lives, so it's crucial to communicate clearly and provide support throughout the process. After resuscitation efforts stop, take the family to a quiet, private place. Speak with warmth and sensitivity, maintain eye contact, and use the patient's name. Be calm and reassuring while explaining what happened. CPR skills can deteriorate over time, so regular practice and training are essential. Hands-on training with CPR mannequins helps maintain high-quality skills. Video and computer-based modules with practical practice can also reinforce training. As an EMT, you are a patient advocate and play a role in public education. Teaching laypeople CPR and AED use can dramatically increase survival rates. Empowering communities with this knowledge saves lives.